welcome. This is Mark from the community manager from Next Community. Today I'm joined with Dr. Ebbert and Dr. Mike Burke from the Nicotine Dependence Center. We're going to have a fireside chat about ensuring that we're taking our medicinal nicotine to help us with our quit journey. Welcome, gentlemen. Thank you for joining today.
Excited to be with you.
Excited to be with you as well. Dr. Ebbert is joining us for the first time here on a live chat. So glad to have him. He is the new director of the Nicotine Dependence Center. And joining us also is Dr. Burke, who is the program director, I believe. So gentlemen, if you'd like to take the mic, I will have some questions and I'll be watching the Q&A session to see if there are any additional questions. But I'd like to hear your thoughts about the topic. So let's get to it.
Okay, well, thanks. So we titled the discussion, the pill only it works if you take it, or, also thinking about, the pill works better in you than it does in the bottle, as kind of a broad concept to think about adherence to treatment, not specifically medication, although we can speak about it today and focus our thoughts on medication, but adherence to any treatment. I'm a general internist, and I've been practicing with an active outpatient medical practice for 26 years. And obviously, key to my success is developing plans for patients and treatment strategies for patients in which they engage. So thinking about that broadly. Now, specifically for tobacco dependence, despite the fact that tobacco kills 460,000 people each year in the United States alone, we only have 3 treatments, right? It's nicotine replacement, and it's 5 in its various forms. We have varenicline, which is, I won't talk about brand names, and we have bupropion. And those are really the 3 medications, that we use. And when we look at clinical trials, that is, in those sort of clinical experience in which patients are participating in science and taking different medications, we see that adherence is anywhere from 66 to 75%. So that is in clinical trials where they're meeting every week with a research, study assistant or research nurse, and actually said, how is the medication going? Here's your next pill. Adherence is not 100%. And that's pretty universal for nicotine replacement therapy and bupropion and varenicline. But when you look in the community, it's even worse. Only 1 out of every 4 patients actually stay adherent to a medication that we prescribe. And we prescribe medication because medication doubles your odds of successful tobacco abstinence. And of course, behavioral therapy plus pharmacotherapy form the foundation of everything we do to treat tobacco dependence. So you don't need pharmacotherapy to be successful. I think that's true. But if you do take pharmacotherapy, it doubles your chances of quitting. So Mike's going to talk a little bit about adherence and what are the barriers to adherence. And then I'm happy to kind of circle back around and think about how to improve adherence to some of our medications.
Hi, I'll jump in then. And first of all, it's really great to be participating with the X community. Over the years, I've always been so overwhelmingly impressed at the amount of generous support and effective support that you all provide to one another in the most life-saving thing that you can do. So I'm glad to be here with you. I should correct you. My title is program supervisor, and I'm filling in for Tim Milbrand. And I probably should apologize for that. Tim is good looking and charming, and instead you got this old coot, so you have to bear with me a little bit here. I want to talk a little bit about taking medications as prescribed. It is important. The medications don't work if they're still in the bottle. as Dr. Ebbert was saying. And adherence to medication is much less than ideal. And there's a lot of ways to look at what do we really mean by not taking the medication as prescribed. And with tobacco treatment medications, even though it's such a powerful life-saving treatment, unfortunately, adherence is less than it is for other medications. And so, take a look at what we mean by not adherence. And first of all, some people never begin medication. We did a survey a while ago now at the Nicotine Dependence Center, and this is verified with a lot of other research, but we looked at people who'd been prescribed medicine, and then we followed up with them by phone in the next month to see what was happening. And like 150 people, we reached about 100 of them by phone. And this is just a couple of weeks after getting the prescription. Only 60% of them were taking the medicine, and only half of those who were taking the medicine were taking it as it had been prescribed. But of the people who weren't taking the medicine, most of them had never picked up the medicine. So they had maybe decided after their appointment that they weren't ready to quit, which is a misconception, really, which I'll talk a bit more about in a few minutes. They might have gotten to the counter and gotten sticker shock. The medication wasn't covered. A lot of people, if they do pick up the medication, they'll just take it sporadically. They won't take it as prescribed, which is another form of non-adherence. They might not be really motivated to quit. They might not really understand how the medication works. They may be having adverse effects that might be due to the medication. It might be due to how they think the medication works. It might be due to other things like, when somebody stops smoking, they stop putting thousands of compounds in their body that come from the combustion of tobacco smoke. That has an effect on how people feel. And it might well be that people misattribute how they're feeling to what's going on with the medicine. Some people forget to take it too, right? And then another way we look at adherence is stopping the medication prematurely. And especially with the tobacco treatment medications, we find that people who have stopped smoking or feel that they should have stopped smoking on the medicine after taking it for a couple of weeks, or after the medication is costing the money, after a little while, they're not going to continue to invest in the medication. If they're quitting, maybe they're getting continuing nausea from some of the medicines, and they'll stop taking over time. What we know is that people who stay on the medications for a longer period of time, up to 6 months with most of the medications, they do a lot better over the long term, even if they continue the medicine after they've actually stopped smoking. So I just want to go back through those three ways of looking at adherence: people who aren't picking up the medicine, people who aren't taking it as prescribed, and people who stop too quickly, to talk some about how we as counselors talk to those patients, the type of education that we provide, and with the hope that you can take some of those thoughts and they might be useful to you as you support people who are coming into the X community who are trying to quit. So people not picking up the medicine because it's too expensive, sticker shock. Now, what's the situation on medical coverage for medication? And the Affordable Care Act, which passed back in 2011, had a defined tobacco treatment medicines as an essential health benefit, which meant that insurance plans were required to cover these medications without any copays. And the letter of the law has certainly not become the reality of the law. And over time, many insurance companies found ways to loopholes in those regulations. Some insurance companies will only cover one medication without covering others. Some medications, some insurance plans will require pre-authorizations. And any of these situations in which too often people aren't covered for the medications, they become a real stumbling block, a real barrier for people starting medication. These medications can all be quite expensive. So as tobacco treatment specialists, we try to look at the coverage. We try to refer people who aren't covered to things like tobacco quit lines, which will support medications through the state. And we advocate. And maybe that's the primary message to the X community, is advocating for the coverage of these life-saving medicines, right? They should be covered for patients. They aren't. And that really is a barrier to people using the medications. Now, we get a lot of people who maybe pick up the medications or don't go to the pharmacy because they're all of a sudden thinking that, well, I've heard a lot about the side effects of those medicines, or they think, well, I'm not yet ready to quit. I need to start the medications. I need to quit in order to start the medications. And there's a lot of misperceptions about the use of medications that become a barrier to people using them as prescribed. And so we try to educate patients about that, but education, the effectiveness of it is limited, right? People have confirmation biases. People have thoughts about things that are already generated. If I say Mary had a little, you're going to think about lamb. If I say use the nicotine patch, people are going to think I can't use it and smoke. I have to rip the patch off to stop smoking. They have preconceptions, and as soon as I raise quitting, they'll be thinking of the withdrawal symptoms, the difficulty in quitting, problems that they've heard from other people regarding medications, thoughts that they're not safe. And these thoughts, these confirmation biases come up automatically. And so we certainly try to provide education about the safety of the medicine, the relative safety of these medications. And one analogy that I use with patients is compared to cigarettes, there's no product that kills it kills 60% of the people who use it as the manufacturer intends, other than cigarettes. So smoking cigarettes, maybe it's like stepping out of the 6th floor window, right? You're 60% of people are going to die. A lot of people are going to get hurt by it. Other things like chew tobacco or vape products, we're not quite sure of the harms of them. It's not as harmful as cigarettes, but harms happen, and that's like jumping out of the first or second story. Whereas comparatively, the medications are like stepping off the curb. They've been tested. Any type of injuries are documented, and the medications are under a particular type of labeling, which unfortunately makes people overly afraid of the medicines at times. So every side effect that's happened in the clinical trials for medications that has happened significantly needs to be listed, as it should be. But tobacco products are under a different regulatory process altogether. I had a patient who had not very long ago, had been diagnosed with lung cancer, and she really wanted to quit smoking, and she was concerned about the medication varenicline, about the side effects she'd heard. And so she and I talked about the side effects that are have been documented. And I said, but if that pack of cigarettes that you have with you had to have all of the side effects documented, each pack would come with a phone book full of all of the different potential side effects. And so as a counselor, we try to use some analogies to talk about the relative safety of the medications. And as a member of the community, when people start taking medications, maybe even more valuable than education is sharing your experience. It certainly helps people get through that confirmation bias to hear from somebody else. I've used the medicines. I found them effective. They help with withdrawal symptoms. They lowered my craving. I didn't have side effects. Not to exaggerate your experience, but to be able to share your actual experience with medications really can make a big difference in terms of helping people begin the medication and to continue taking it as prescribed. Another problem people sometimes have in terms of adherence is forgetting to take medication. And we, as tobacco treatment specialists, we follow up with patients. We ask, how are things going with using the medications? Reassure people about safety and effectiveness of the medicines, and then ask, you're taking it as you should. You're using the patch daily, or you're taking varenicline and bupropion as you should twice a day. And often people just forget. And at that point, talking to people about just habitual ways of remembering to take the medication. What's something you do every day? You brush your teeth. Maybe if you keep the box of patches right by your toothbrush, that'll help you remember. Or asking our patients, tell me, what are some of the things you do to remember to do things regularly? Like, where do you put your keys? What are some of the things that you do that help you remember to do things that you find are important? And we connect that with using the medication. And again, as a support person, somebody's new to the community, just beginning medication, to just ask the question, how's it going with taking it? How are you remembering to take it? That can really make a world of difference for your fellow ex-members, as I think it does with our patients too.
Mm-hmm. Dr. Burke and Dr. Ebbert, I actually had a question from the community. Two members have recently brought this up, kind of being a little tangential, but there's two members that are having an upcoming surgery, and their surgeon said they won't provide the surgical procedure unless they're free of nicotine. Do you have experience with that, where you work with surgeons at Mayo Clinic that won't do a procedure until the patient is free of nicotine? Kind of the additional question I have there is, are there any tests that can show that a person is only using medicinal nicotine replacement therapy, and not using actual tobacco products anymore, that could get them in the clear so that they could have that medical procedure?
Yeah, so it's a great question. We deal with surgeons all the time, and it's really a surgical preference, right? You can present the data, and the data suggests that it doesn't impair wound healing. In fact, we know, as in our experience, that patients, if they're not treated, relapse more quickly, and their surgical outcomes may be worse,
Mm-hmm.
right? Because the surgeon's like, great, you didn't smoke before surgery, but within 72 hours after the surgery, they're smoking again because they weren't treated adequately. We think that's a bigger problem. And so we have that concern. Some of the data that suggests that nicotine impairs bone grafting comes from animal studies, but patients aren't animals. They're not rabbits, and they're not rats, they're people. And there's additional layers of complexity there, that rabbits were not previously exposed to cigarette smoke before they had the nicotine that impaired bone grafting. So we believe that the outcomes are better, even in the setting of nicotine, but the surgeons won't operate. So we got to get through that. So the options include being on varenicline. So sometimes, varenicline, remember how varenicline works. So you have a lot of nicotine receptors around your body that the nicotine replacement therapy connects with, and they're in your brain, which is where the center of reinforcement is, and they're in your body and your intestines, all those places that seem to change or have manifestations of change when you stop smoking. I have patients that say, stop smoking, I can't have my morning constitution, right? They can't have a bowel movement in the morning without their cigarette. That's because there's nicotine receptors in your colon. So the point is that the nicotine goes all over the body, and where really one of the most powerful effects of that nicotine receptor is in your brain, and that's where varenicline acts. But varenicline is a non-nicotine replacement therapy. It's not nicotine. It doesn't act like nicotine. It only acts in a very specific receptor of your brain. So sometimes surgeons are okay with nicotine. If they're not okay with nicotine, they're okay with varenicline. And then bupropion too is another very effective medication that's not nicotine replacement that surgeons don't seem to have a problem with either. And then the other opportunity is just, if they don't want you to be on any of those meds, which I really can't imagine, but being far enough from the surgery to make sure that you're abstinent without any of those medications is probably going to be key. So with the stress of recovering from surgery, that's not a trigger for relapse and then having an adverse outcome. There are urine tests that we can do. So when nicotine is absorbed in the body, it's broken down by the liver into a product called cotinine as a metabolic product of the nicotine breakdown pathway. And then the cotinine is urinated out and excreted from the body. Cotinine is not metabolically active. Nicotine, if you administer it, gives people reinforcement. It increases their energy level. But if you give them cotinine, they don't have any effect. It's not pharmacologically active. So what we can do is there's nicotine and cotinine in nicotine replacement, and there's nicotine predominantly in nicotine replacement. And in tobacco, there's also these other products. In a tobacco product, we see other what we call tobacco alkaloids. So nicotine is a tobacco alkaloid, which, for interest, the plant makes nicotine not so that we can smoke it and have a reinforcing effect from it. The plant makes nicotine to protect itself from bugs. Nicotine is an insecticide. So nicotine is made by the plant to protect itself. It also makes other chemicals to protect itself, such as antitabine and anabasine. And if someone's using a tobacco product, we can detect anabasine and antitabine in the urine, and we say, aha, that person's using tobacco because we see these other alkaloids in there. But when we look in the urine of someone who's using nicotine replacement, we shouldn't see those. So we can differentiate based upon these markers. And I frequently get calls from surgical teams saying, Dr. Ebbert, this urine looks like this. What do you think? And frequently it's almost universally the same question. We see cotinine. And I said, yes, but you don't see anabasine and antitabine. That person's not using tobacco. So we help with that. And that's particularly true in the transplant space where obviously the stakes are very high, for maintaining that person off of tobacco, and surgeons will flat refuse to transplant someone who can't get control of that addiction. So I think that was it. The question was, what do we do perioperatively? And then are there tests that we can leverage to make a diagnosis of tobacco use versus just nicotine replacement therapy use?
No, that's great. I think we should provide some resources to help arm people with those suggestions about the tests that will help identify whether it's plant-based nicotine or nicotine replacement therapy. Excellent. Thank you so much for sharing that. I know that will be encouraging to the two members who are asking about that. The other questions that I had, with respect to varenicline or bupropion, there's certainly some concerns about mental health and potentially interactions with other medications that the people may be taking, and that may be a barrier to continue with the medication. How do you address concerns about mental health or interactions with other medications they may need on a daily basis?
Mike, you want to take a swing at that?
Yes, I will, although I think you can provide a fuller answer. But with varenicline, there were a lot of concerns at first that it was having neuropsychiatric side effects, increased suicidality, anxiety, depression. And there was a large study done, recruited 8,000 people, and it put everybody on either active medication, nicotine replacement, varenicline, or placebo. And in that study, they actually recruited people who had significant mental health problems. It was a tough study to do, but they recruited people with major depression and psychiatric disorders, and they found that people on the active medications did not have more suicidality, more anxiety, more depression than the people on the placebo. So the people on the placebo may have had a little more of those side effects. The two side effects from varenicline in particular, nausea and vivid dreams, happened in the active treatment group. And so those are adverse effects that we caution people about. But in terms of the mental health side effects, varenicline doesn't seem to be causing that in studies anyway. Bupropion's a little bit more of a complicated medication, so I'd like to hand off to Dr. Ebbert, see if he has more to say about the varenicline and to also add about the bupropion.
Yeah, I think Mike summarized it well with the varenicline. What I'd say about bupropion is it has a couple more drug interactions. Bupropion is an antidepressant that has a dopaminergic and norepinephrine effect, as opposed to like your traditional antidepressants, which are more serotonergic. So it works differently than a lot of the classic, what we think of classic antidepressants. And if we have someone on a classic antidepressant, lots of brand names out there, but citalopram and paroxetine, and those are medications that are safe to use with bupropion, and frequently we do. And in fact, clinically, this may or may not be interesting to the community, but when a patient presents to me with erectile dysfunction, which is not an uncommon side effect from an antidepressant, one of the treatments is to give them bupropion, because it seems like that norepinephrine dopaminergic effect sort of counteracts its serotonergic effect of having erectile dysfunction. So safe to use, we frequently use it. It's a clinical tool that we use. And so we just need to be careful. And we do, when we have an electronic health record, as many providers do, that does check that for us. And then we can, sometimes what we'll do is if we get an interaction with bupropion, we add it, but then we might decrease a little bit the dosing or the daily dosing of one of those other antidepressants to make sure that if bupropion is increasing the level of those antidepressants, we can decrease the dose to keep patients safe. Because to Mike's point, which is how we started this conversation, if they're having side effects, they're going to stop the medication. And so we have to be smart and proactive about making dose adjustments. Go ahead, Mike.
And just in terms of interaction between medications, varenicline is actually very safe. One of the reasons that medications interact with one another is they mostly all get metabolized through the liver, so they compete with each other for liver time and back up in your system. Whereas varenicline, it does what it's supposed to do, interacts with the nicotinic receptor, and then leaves via your kidneys, so it really doesn't interact with any other medications.
Excellent. I'm glad, Dr. Burke, that you addressed some of the other questions that I had, to potentially ask you, people's concerns about affording medications and whatnot, and being an advocate to your health plan to hopefully get access to those medications. The other question that has been answered yet is, how do you address people who have kind of a fear of using nicotine replacement therapy and the concern about potentially getting addicted to it? There's some polarization in the community and every flavor in between of people who are strongly against nicotine replacement therapy and others that are an advocate of it. But certainly there is some concern, and an occasional person comes on and says, hey, I'm addicted to taking lozenges, or I'm addicted to the gum. How do you help people who maybe have that worry that those nicotine replacement therapies may provide another addiction?
So I guess I'd ask the question, if I was with my patient, I would, and I would say, is this an informational gap for you, or is it just a philosophical approach? Because if it's a philosophical approach, there's no amount of information that's going to convince you. It's just the way you want to behave, and we have to respect that. But if it's an informational gap, in terms of, thinking about, first of all, they are taking nicotine. And the other thing is, I think you need to broaden your understanding of what addiction is. So we define addiction broadly as having tolerance, that is needing higher and higher doses to get the same effect, having dependence, that is when you stop it, you have withdrawal, and having adverse consequences from its use. And so when we think about, you may be dependent on nicotine, you may be, and that may be with nicotine replacement. I mean, that is potentially what in the early stages of treatment, they might need that. Otherwise, they have withdrawal. We don't see a lot of dose escalation with nicotine, but if we can get rid of that third component, that is adverse health consequences, you will not die from nicotine. End of story, period. And Mike maybe has a different philosophy, but I've been doing this job for 26 years. And I've watched my patients die with the cigarettes in their hand from metastatic lung cancer, and I couldn't get them to quit. So I have a very different approach to this, and that is, if that patient had used nicotine for the rest of their life, I would consider my job completed, and I would have considered my job, I would have been thinking of that as a job well done and success, because they're not dying from tobacco. Nicotine's not going to kill them. And then there really becomes, what are you worried about? Why are you worried that you're taking nicotine every day if you're not smoking? Like, what's the concern? And sometimes I have this interaction. I want to be drug-free. And I go, okay, let's talk about the Ativan you take. Let's talk about the Ambien you take. Let's talk about the 3 cups of coffee. Those are drugs too. And I'm not challenging them. I'm just saying, let's be philosophically consistent and not carve out this because we've demonized nicotine, which is not a demon. For many people, nicotine is salvation. For many people, nicotine saves their lives, period. And you can have a different philosophy, you can have a different approach, but that's mine.
Thank you.
And I agree wholeheartedly with that. And one thing about nicotine replacement, addiction is partly a function of how much of a drug is delivered, how quickly to the brain. Lighting tobacco up and inhaling it delivers nicotine more quickly to the brain than a hypodermic needle. It's very addicting. Vape products have evolved over the years to imitate nicotine delivery from cigarettes because that's highly addicting. There hasn't been an epidemic of kids in high school using patches and nicotine lozenge because it isn't as reinforcing. It delivers the nicotine very differently. And the nicotine patch has no addiction liability. Some people will transfer addiction to the lozenge or gum, or even more to the nasal spray. But still, they're not as addicting as these products designed to addict. And for most people, you start using those products and you lose interest after a couple of months.
Mm-hmm.
And sometimes when I'm with patients, especially when I spend a lot of time with patients, in that there's a light bulb moment when we actually, so we've demonized nicotine. We've demonized it. And Mike and I have been working together long enough that he hears me saying the same thing over and over again. It's very challenging to say that nicotine is the demon. Oh, by the way, your treatment plan includes 3 nicotine products. It's like, it makes patients feel insane.
Mhm.
And I don't blame them. That's crazy making approach to clinical medicine, is you're giving them the treatment that you just demonized. The demon is tobacco. And to Mike's point, I would just emphasize, addictiveness of any drug is related to the speed it gets into the brain. And these products are very slowly into the brain. And I always tell the patients, because they'll say, if you give me as much nicotine, Dr. Ebbert, as I'm on when I smoke, I'm not improved. And I said, disagree wholeheartedly. Number one, you took the speed of delivery away. That's a huge step, even if you're on the same dose, and you're no longer using tobacco. And then over the next 3 months, we can get you to where you want to be. But if I can get you off of the tobacco, I'm happy.
Do you push people more towards patch because you can control the dosage they get, whereas gum and lozenges, I know on the community people discuss like, hey, you could potentially be popping 50 lozenges in a day, and your nicotine level could be very high as compared to using a patch, where some people have irritation in the site that they put it, but that controls your dosage through the day.
I work with patient preference. I'll say, which ones are you willing to use? And I did a lot of, in the early 2000s, I did a lot of smokeless tobacco research, and this would always be the conversation I have. Well, if I put gum in there and I'm trying to quit chewing tobacco, it feels just like that behavior. 50% of the patients say, I want that. 50% of the patients say, I don't want that. So who am I to say? I just go, that sounds good. Let's get as far away from that behavior as possible and just work with the patches and not the gum. The other person, I'd say the opposite. Let's get as much gum as you need. And the other thing I'd say that we always say philosophically is that patients who come to me have an advanced degree in the neuropharmacology of nicotine. They know what it feels like. They know how much they use. They know what it feels like when they don't have it. They know how quickly they have to smoke. They know nicotine as it interacts with their body. So that's why I let the patients lead the way. If they feel like they need to have as many pieces of gum as they want, and I'm sorry if I'm saying something off label and we're not supposed to say that, but I just say because you know what it feels like. 100% of the time when I say, what it feels like when you've had too much to smoke, right? Or you smoke too much and like, oh yeah, you get that. No, same thing. Nicotine's going to feel the same way. When you have too much nicotine or too much patch plus, nicotine gum, you know what that feels like. They all know what that feels like because they have advanced degrees in neuropharmacology of nicotine.
Well, this has been an amazing discussion. Thank you both so much for your time. I certainly learned some new things and have some new perspectives about things, and hope that the people who watch this video after we post it will gain the same thing. So thank you both so much for your time today. This has been a event sponsored by the X community on becomeanx.org. Thank you so much for your time, and have a great day.